Good morning and welcome to our webinar today entitled PDPM is Here, the Transitional IPA and Beyond. My name is Ken Bell. I'm the Vice President of Marketing for SimpleLTC. Thanks so much to everyone for joining us today. So with just 5 days left until October 1st, the clock is ticking very loudly, and many of us are trying to picture how the SNF world will be different after next Tuesday. And so that's one of the things we'll be talking about today. So one of those significant changes is related to the Transitional IPA MDS assessment, which will be instrumental in setting a baseline for your reimbursement going forward. So we'll discuss that today, as well as some of the critical communication during your first 8 days to get to know your residents, which is critical on a long-term basis for patient care and for your payments. We'll also look today at opportunities you can discover inside your SNF analytics, which can help awaken your clinical skills for a PDPM world. So today's webinar, we're happy to say, is brought to you by the Texas Medicaid Coalition. We've been partnering with TMC for quite some time now. TMC is an organization of Texas long-term care providers focused on maintaining and improving Medicaid reimbursement. So if you have Texas facilities and those facilities are concerned with Medicaid reimbursement, and all of them obviously are, especially after PDPM, you should definitely get them involved with Texas Medicaid Coalition. It's a great organization. You can learn more and apply for membership, which is free at their website, and that address is medicaidtx.org. Again, that's medicaidtx.org for the Texas Medicaid Coalition. So we appreciate them organizing and working with us on this training today. And SimpleLTC, that's our company. We're your host for today's training. We're a long-term care data analytics company serving over 4,000 facilities around the country. Our MDS analytics software, which is known as SimpleAnalyzer, helps facilities improve MDS quality measures and workflow, as well as prepare you for regulatory change like PDPM. So for more information about that and our other products, you can visit our website at simpletc.com. Okay, so before I introduce our speaker this morning, a couple of quick notes. Handouts, we always get lots of questions about those. Those are currently available. Melina with SimpleLTC is with us today, and she'll post a link to the handout PDF in the chat section if you don't already have the file. And so that's in PDF format, and you can download it now from the chat section. Also, regarding questions and answers, you can ask a question at any time during the webinar. You have a Q&A box on your webinar panel. You can just click on that and type in a question at any time during the session. Melina will be monitoring those questions as they come in, and then we'll present as many of those as we can to our speaker in the Q&A portion at the end of our session today. So we'll try to reserve as much time as we can to cover as many questions as possible. Okay, now I'd like to introduce our speaker, Susan Kroll. This is the second webinar we've done with Susan and QRM. Susan is the Chief Strategy Officer with Quality Rehab Management, also known as QRM. Susan's a physical therapist with 30 years of multi-state post-acute experience, and her client base at QRM includes privately owned and nationwide facilities in both the for-profit and nonprofit spaces. Susan's focus with QRM is partnering with clients to identify and implement strategies to drive enhanced outcomes and patient satisfaction. And she describes herself as a PDPM enthusiast and has been training SNFs on PDPM and getting ready for it for the past year. So we're happy to have her expertise on our webinar today. Also with us, one final note, is Corey Pauly. Corey is the Director of Product and Software Engineering for SimpleLTC, and he'll be covering a little bit of the data analytics as we get deeper into the presentation today. Okay, so with that, I'm going to go ahead and turn it over to Susan to get us started.
Thank you, Ken. I'm very happy to be here and cannot wait to see all the teams come together and put this into play in the next few days. So I think you covered the agenda really well, Ken, so let's just go ahead and go to our first poll if you're okay with that.
Okay, great. So we do have a quick live poll we're going to present to everyone. So this is just going to help us get a baseline of where everyone is right now. So we're 5 days out from October 1st. So what do you think your competency trainings are? What are the priorities prior to 10/1, prior to October 1st? ICD-10 education, BIMS, PHQ-9, those kind of topics. So take a look at that on your screen and give us a quick vote. We'll leave this open for just a minute or two, and then I'll share those results so we can kind of see where we all are, and you can compare yourself to your peers as well. Okay, we're watching the results come in right now. It's kind of not too surprising from what we're seeing. I'll share those in just a minute. But yeah, if you haven't yet, please just click on your screen real quick and give us a quick vote, and we'll share that in just a second. Okay, we'll leave that open for just a couple more seconds. Kind of wait until we get at least 50% of our audience. We do have, I haven't looked at the numbers yet, but I'm sure we've got a couple thousand people on the line today, so this will be a pretty good representative sample. Okay, we've got about 50% of our attendees who voted, so I'm going to end that and then share the results. And then you guys can kind of see where you are. Susan, what do you think? Any surprises there?
No, I love it. I definitely agree with that, what I'm hearing. I was just asked yesterday for what I felt like some of the roadblocks that people were really struggling with. And the first thing I said was this whole capturing of the granular diagnosis codes to really represent the primary reason for the SNP stay, as well as the speech comorbidities and the non-therapy ancillary categories. So that is exactly spot on. And then I have also, this is a whole GG rework. So we've been used to just taking the rehab information and using that for GG in this industry, and it cannot happen that way. It's got to be usual performance. So there's been a ton of effort on that, and of course the nursing documentation has to be there to back up everything that we put on the MDS, and I love seeing that that's been a real focus. And then that non-therapy ancillary is just such a huge opportunity for us to really finally capture the conditions we're treating so that we can afford to care for these people that we're getting. So I totally agree. I think that's a great representation.
Okay, great. So we're going to go ahead and move into the presentation now.
Great, thank you so much. So I'm just going on now to the CMS's updated links, and I think that they have done a great job. If you just click on that first CMS PDPM website, you will find the below buckets of information. I really like their frequently asked questions. They really just updated those on 8/30/19. So I find that that's a great resource to look at first if you have a question. And then the PDPM training presentation clearly covers the basics of the model. So if you've got some high-level stakeholders, investors, physicians, other partners that need some education and training, I think that's a great place to go. It's directly from the source, so that's always a good thing. And then other PDPM resources found there that we have to go to on a routine basis. Everybody needs to have that PDPM ICD-10 mapping at their fingertips every single day in every discussion to make sure that our diagnosis codes are going to map to one of the primary clinical categories. And if it is a speech comorbidity that you have to enter into I-8000, then you have to make sure that it crosswalks to one of the comorbidities. And the same thing for the non-therapy ancillary. If it is found in I-8000, you have to map it in the NTA tab to make sure it's going to be captured as an NTA component and that you're going to get credit for those points. So those are my favorite resources. They're straight from CMS. Can't go wrong with that. And then we're going to go over to, again, I've pulled from the FAQs from CMS how this transition from RUGs to PDPM is happening. So I think this is clearly old news now, but just in case, the transition between RUG-4 and PDPM is a hard transition. So the two systems will not run concurrently at any point. So all days of service on or prior to September 30th are going to be billed under RUGs-4, and all days of service beginning October 1st will be billed under PDPM. Now, I have heard some questions about, do we need to discharge our patients at the end of September? No, you do not. Your original Medicare Part A admission date remains the same on all of your documents through discharge. So your admission to Medicare date remains the same. It's the date that the person came in, whether it be September, August, July, whatever it might be. So hopefully that's been cleared up. And let's go on to then the next FAQ that we pulled is that, again, to clarify payment, the only way to receive payment for your Medicare Part A patient days or your managed care patients that are going to follow PDPM rules, the only way to receive payment for those patients for October, from October 1st and beyond, is to complete that IPA with an ARD no later than October 7th. October 1st is considered day one of the variable per diem schedule, even if the patient began their stay prior to October 1st. So that is a fantastic opportunity for us. That means we will get paid 3 times the base rate on what you have captured in your non-therapy ancillary category. And for your PT and OT variable per diem, that drops after day 20. Day 1 of that count starts on October 1st, no matter how long they've been in the building. So I want to make sure that that's clear. And any transitional IPA that has an ARD date after October 7th will be considered late, and the late assessment penalty would be applied. You don't want to be late because you don't want to have to take a default payment in those first few days in October and miss out on that NTA triple amount. So this is an opportunity for us to get this right. So the HIPS code that's going to tell Medicare what to pay us is going to be derived from the transitional IPA, and it's going to be used for bill for dates of service from October 1st until the discharge of that patient, unless you do another IPA. So the PDPM assessments, let's talk about those again just as a review. The required PDPM assessments going forward are the initial Medicare assessment. I think we've called it a 5-day assessment. We've called it all different kinds of things. I believe at this point we're calling it the initial Medicare assessment. That is the requirement going forward after this transition. And then your discharge assessment. Those are the only required assessments from a reimbursement system. Your OBRA assessments do not change. They remain the same. Your optional interim payment assessments after the transition are intended to capture the new reimbursement level. It's optional. It's totally based on the IDT's decision as to whether or not a new IPA, a new payment level, needs to be captured. When you do an optional IPA assessment, there's a 7-day look back requiring your new GG, which is always on the IPA. The GG is a capturing of information on the ARD date and the 2 days prior, and the BIMS and the PH29 have to be redone. The reimbursement changes on the ARD date, and it is, again, optional. It's only completed when deemed necessary by the provider, and it will determine your payment through discharge unless another optional IPA is completed. Then we have our required transitional IPA, which is what we're talking about today. It's our one-time transition document. An ARD date no later than October 7th, 7-day look back. Some items have a 14-day look back. So we're in look back windows now, right? It's okay to look back into September if it's included in your look back window. The variable per diem, as we said, starts on October 1st, and payment determined by the IPA is effective 10/1 through discharge, unless an optional IPA is completed. So we'll talk a lot more about that in just a second. CMS, again, as a reminder, is retiring the 14-day, 30-day, 60, and 90-day assessments, and any SOT, EOT, COTs, and EOTRs. And the short stay assessment doesn't even apply any longer. One thing to always remember, the IPA assessment, including the transitional IPA, cannot be used in conjunction with any other assessments and has no impact on assessments completed through the OBRA requirements. So you might have two open at the same time here, right, in the September transition, an OBRA document and your transitional IPA. So let's talk a little bit about that variable per diem again. So in October, anyone transitioning October 1 onto PDPM will be able to take advantage of the variable per diem starting on day 1 of October 1st. After the transition, the variable per diem schedule starts on the admission date. So the variable per diem, again, impacts PT and OT beginning on day 21 with a drop in reimbursement, 2% every 7 days, and the non-therapy ancillary reimbursement is multiplied times 3, day 1 through 3, then reverts to a multiplier of 1 for the rest of the stay. The interrupted stay. This has been a topic of a lot of discussion. I try to keep it as simple as possible. The intent of the interrupted stay, according to CMS, straight out of their words, was that it was designed to mitigate provider incentives to discharge and readmit the patients to reset the variable per diem payments. That would be quite handy to get 3 times the amount on that non-therapy ancillary every time they went to the hospital and came right back. So the interrupted stay criteria is that if a resident leaves a Part A stay and returns to the same SNF, and if the resident returns by 11:59 at the end of the 3rd calendar day, so within 3 midnights, then that is an interrupted stay. Then the variable per diem does not reset with an interrupted stay. It only resets if the patient is gone from the building more than the 3 midnights or admits directly from another skilled nursing facility. So I hope that that's cleared up a little bit by now. So we're going to go on and talk a little bit more about the transitional IPA and some considerations. I think I've said this over and over, I'm sorry to repeat myself, but just in case, ARD date for this transitional IPA can be no later than 10/7. We have to use a date when the resident is in the building at midnight. The default rate does apply if you're late, and the provider liable if you miss it entirely, which that would be a nightmare. We can't have that happen. The look-back window can go into September. Some of the items do have a 14-day look-back, which is important to note. So the objective of this is to capture all of the current active conditions and characteristics. So we have to remember that when that patient admitted, some of those conditions that we captured on admission prior to October 1st may have resolved. So we have to look again, and we should take this opportunity. We only have 5 days left, but we need to have taken this opportunity to re-look at all of the active conditions on anyone transitioning over, make sure all of the documentation is there to support it, and make sure the physician's diagnosis has been captured within the last 60 days. So this is a renewed assessment of our patient. We cannot take the same information that we had before. In fact, we have to do a new GG item set. It's an interim performance capture, and it will be the window of the ARD date and the 2 days prior to capture the true usual performance. We know that they've already had a benefit of therapy, so that's going to be a little bit tricky. It's going to be different than our initial baseline, I would imagine. And don't forget, we have to establish at least one GG goal and make sure that goal is care planned. So we need to have a redo on our GG. So we are in that, we could potentially be coming upon that GG window. We have to make sure we have a good system in place to capture what happens at the bedside with the CNAs with those patients, because that's what happens usual. That is, how many times do they move in the bed outside of the time they spend in therapy? How many times do they transfer? How many times do they toilet, eat, drink, take care of their oral hygiene? Those are all things we have to make sure we capture from the bedside, not from therapy. We also have to make sure that we capture a new BIMS and PHQ-9. There's 161 items on the MDS that drive your HIPS code and your new PDPM categories. So we have to redo all of those in the IPA assessment. It's not just these items that I'm calling out right here, but we do need to make sure that there's a new BIMS and a new PHQ-9, and it might be different, highly likely. If you're going to capture restorative, if you have a plan to have restorative involved, then we need to make sure that the plans are in place, the plan is written, that the RN or nursing supervision is in place, everyone understands the requirements on documentation and timekeeping, and that we have a good system to capture all of the days and minutes that have been delivered in restorative. Again, the payment begins on 10/1 based on your PDPM HIPS category as captured in the first 7 days of October. It might not be the first 7 days in October, it's your assessment window based on whatever assessment reference date you chose, day 1 of October through day 7. The variable per diem count begins 10/1, and the Medicare start date again remains the original start date of this Medicare Part A day that the patient is in. So let's look at some other tips on ARD readiness prior to 10/1. So when I wrote this, we had several more days, but here we are looking at 5 days left. So business days, we only have 3. So right now, and a lot of people are using trackers. We have a tracker at QRM. If you don't have a tracker, let us know. But a lot of people have the patients already listed out on their tracker. They've already selected the ARD date they feel is going to most accurately capture what's going on with this patient, to capture all their active conditions, characteristics, and comorbidities. So if you haven't already mapped out your ARD date for your patients transitioning over, I would say now is a good time to do that. We want to make sure that all the ICD-10 codes have been confirmed for all of the residents in advance of the ARD date using your mapping tool. The primary reason for the SIP stay may have changed. Then that condition that you captured on admission may no longer be the primary reason for the SNP stay. So again, we have to have that interdisciplinary team discussion about why is that patient still requiring skilled nursing care? What is the primary reason now for their stay? You have to make sure the speech and the non-therapy ancillary items that are found in I-8000 have mapped, and that we have a accurate physician diagnosis in the medical record to support that. So we are already in a window potentially for some 7 and 14-day look-back options as early as September 19th. So if you haven't already checked your documentation for all of the above conditions and treatments and order changes and interventions, now would be the time to do that and all the patients transitioning over so that your MDS coordinator is not completely overwhelmed and burdened with this task alone. It's an interdisciplinary team effort here. So let's, again, talk about the IPA considerations after the transition. So let's get through the transition and talk about what's in our future. One thing that we have new to think about ongoing is, do we need to take an IPA after the transition? Why would we want to take an ARD? Why would we want to take an IPA? Some people have policies written, some people don't. It's not a requirement. I've heard it mentioned as a suggestion, but many people have put some bullet points together for their teams so that they have a process to continually look at, has there been a significant condition that would warrant us doing an analysis to see if an IPA should be taken? And I think everyone understands at this point it is not to be taken lightly because conditions resolve along the way. It could definitely impact your reimbursement both ways. You need to know how it's going to impact you before you take it, because it does take new GG items, which are a driver of your reimbursement for your PT, OT, and your nursing categories. So if your GG has changed dramatically, your reimbursement would change dramatically, as well as your BIMS and your PHQ-9. So you have to do an assessment. If you don't have some sort of a tracker or a calculating tool that you use, we also have one of those. You definitely want to do the math. We want to remember that the ARD on any IPA can be set for any day of the SNF PPS date after the 5-day assessment, ARD. So if you're taking an IPA into the future, it has to be after the ARD of the 5-day or the initial Medicare assessment. So it has to be completed within 14 days after the ARD, and it authorizes payment for the remainder of the stay beginning on the ARD. It does still have to be submitted electronically and accepted into the system within 14 days after completion, and it cannot be combined with any other assessment. So that's the IPA consideration after the transition. Let's not forget that we still have a few days left in September, and before we submit those claims, we want to make sure everything is accurate. We have not missed a beat. Have we accurately captured September RUG levels? We have 5 days available at the end of September. We might still have new admissions. I'm sure we do. If they need rehab, we need to ensure rehab availability. If there's a potential that if they do need therapy and there's potential to get 5 days in, I would imagine you would want to make sure you get that in if that's the need of the patient so that you can accurately capture that need. And if you have any COT, EOTs that occur between now and October 1st, make sure that you accurately follow the current PPS rules so that you don't incur any penalties. We get a lot of questions about the short stay. Can we take a short stay? Can we not take a short stay? So I've outlined all of the 8 Medicare short stay assessment requirements. They all have to be true if you're going to take a short stay at the end here. So make sure before you think about a short stay, you review those items thoroughly with your team. Okay, let's talk about the new MDS assessment and schedule. We'll review that again. The initial Medicare assessment after this transition will have an ARD date of any day 1 through 8. Let's not forget that you don't have to wait to get your 5 days of therapy and your minutes in. You can look at this pre-admission information that you should be gathering now and decide, did something happen in the hospital that you want to capture? If so, that needs to come to you day 1 from your pre-admission team telling you, hey, we had an IV or something in the hospital stay that you want to capture, so that the team on that first day when you meet after admission can decide what is the best ARD date to capture the most active conditions that we are dealing with upon admission for this patient. So your pre-admission information should really help you set your ARD date with your initial Medicare assessment. And then we go to the IPA, which is optional. After this, again, we're looking in the future. No later than 14 days after the change in classification was an initial recommendation, payment day, ARD date, through the discharge unless you do another IPA. Do not take an IPA unless you've done the math and you know how it's going to impact you would be, I think, the recommendation. Then you have your discharge. Your discharge assessment is very, very important now. It is the Medicare Part A end date, and it does not impact your payment whatsoever. However, This is the document that's going to be used to gather your days and minutes of therapy provided since the initial Medicare assessment, or since the initial admission of the patient. So Medicare is going to be using the discharge assessment to monitor how many days and minutes of therapy did you give, individual, group, and concurrent, as compared to historical days and minutes of therapy delivered. It's going to look at your outcomes if you have a significant drop. They have told us that. And they're going to look at the GG item sets. We're going to talk about that more later. But your GG on admission needs to be your baseline. Really, truly your baseline. Before the benefit of therapeutic intervention, what did we get this patient at? What level? And then at discharge, how did we progress them? Did we meet their goals? What was the difference upon discharge for their functional status? That is really, really important, and we've not really paid enough attention, I don't think, to the GG discharge scores. So that would be something I think we need to pay a lot more attention to as an interdisciplinary team, and don't just go with what therapy says they've made as far as progress. Now we go to what's our new first to 8 days look like in that 8-day window. Day 1 through 8, any date for your assessment reference date. Knowing that you might take a day earlier than day 8 now, I've really front-loaded some of these tasks in our first day window. At this point in time, I would move the BIMS and the CPS up earlier in this day. Again, we want to capture. We don't want to miss completion of a BIMS. And if they can't complete the BIMS, the cognitive performance scale. We don't want to miss that, nor do we want to miss the PHQ-9. Scooch those up so you feel good about making sure you capture it. Make sure you've got that first 3 days, a system in place where you are capturing the usual performance in those first 3 days. Of course, it starts all with pre-admission. Make sure the first day you have a meeting that you're talking about everything gleaned from the hospital discharge records, such as they are, from the communication with the family and the patient. Make sure you've got the pre-admission status down pat so that when you set your initial baseline care plan, it's based on truly the needs and the goals of the patient. Where are we going? Address the barriers to why they did not go back home or wherever they came from, and do a really good interdisciplinary job of assessing the needs of that patient. Look at your GG information gathered through those first 3 days, and by day 4, you should have an impactful meeting where you're able to set the GG score as a team, make a note of that, and then go to town with making sure that you've got the right goals, everybody on the team knows the goals, and that we're all working in a united, collaborative team effort towards safe transition of that patient. And then in the meantime, we have got to, by day 4, I think we should have a very good head start on finalizing all of our diagnosis, our comorbidities and conditions, so that when we take that ARD date, we feel really good about that documentation and the diagnosis codes being spot on in that medical record. So I think you'll get the first 8 day importance, since that drives your reimbursement for the entire stay. I cannot stress enough the importance of the collaborative discussions and making sure you feel really, really good about that initial MDS. That will get you through your triple check and your audits and keep you safe. So just a quick glance again at the 6 components of PDPM. We've beat this up one side and down the other. There will be reimbursement in every single one of these PT, OT, speech, nursing, and non-therapy ancillary buckets. You'll also have that non-case mix group with that amount of the base rate that's set by CMS. Each one of those will stand alone. They will be totaled together to get your residents' total daily rate. Whether you deliver PT, OT, or speech or not, you will have that daily rate given to you based on the needs of the patient, which is what drives the reimbursement. Obviously, a note of caution, someone has to skill this patient. That needs to be decided upon admission. Who is skilling the patient? Day 1. What are the needs of this patient after the assessment, the screens of the therapist? What is it that therapy needs to do? The interdisciplinary team needs to decide what interventions are indicated and need to be delivered. So it needs to be a team decision now for the interventions of PT, OT, and speech based on the findings of the patient's needs. So as we look at the PDPM model and the MDS drivers by section, these are the sections on the MDS that we need to pay specific attention to, because these are going to be where we get audited. This is what's driving your reimbursement. So we know that we've got section B, driving speech and nursing. We've got cognition at the BIMS. That impacts speech and nursing. We've got our PHQ-9. We've got our behavior that can drive that behavioral category. GG functional abilities impacts PT, OT, and nursing. You can see balanced bladder impacts nursing and the non-therapy ancillary. Your active diagnosis will drive reimbursement for PT, OT, speech, nursing, and non-therapy ancillary. It's no wonder that that's one of our highest areas of concern, making sure we have those diagnoses right and that they map correctly. And then we're looking at all the health conditions for PT, OT, speech, and nursing, and swallowing. It's big for speech, nursing, non-therapy ancillary. That malnutrition is a NTA category, or a component for capture. We've got our skin treatments and conditions, our meds for nursing, and our special treatments, and procedures and programs, all that take place while a resident that impact speech, nursing, and non-therapy ancillary. So you've got to make sure that people are assigned and tasked with monitoring the information that goes into the medical record and then carried over onto the MDS, part of our triple check. I'm going to turn it over to Corey now to talk about what they found when they did some initial preliminary samples of what we're capturing. Corey?
Yeah, sure. So what you're looking at here is data pulled from one of SimpleLTC's products, SimpleAnalyzer. So we, starting in October 1 of 2018, we started asking our customers to record the primary diagnosis in I-8000A. And this is kind of the default for big EHRs like PCC. And the numbers we were looking at, so I ran the numbers in January, for January 1 of 2019, about 41% of residents had a return to provider primary diagnosis. So that would be an invalid primary diagnosis that would be rejected come October 1 in a few days. We ran the numbers again for July 31st. So I ran these a little later in August. And that number went down to 3% of these stays. In total, we had about 21 to 22,000 stays. We used a static list of providers to provide this, to calculate these numbers. So this is a good indication that people have been focusing pretty well on training for coding for the primary diagnosis. It's a little bit of an under the table brag. So people that are using analytics tools like this have done very well at preparing for the Section I piece of PDPM.
Fantastic. Good job. So it proves the point that with focus, we can make changes on this, and we can really start capturing what we're seeing, the patients that they come to us. So I'm going to start I'm just going to take a little glance at Section GG and just reiterate the fact that this is a new way of gathering information. We were used to Section G driving the reimbursement under the RUG level, and with GG, it's completely inverse in our coding, and the questions are different. So we're no longer asking, as we did in G. In G, it was in the 7-day look back, what was the most help that that person needed in that look back window? That's not what we're asking anymore. Now what we're asking is the usual performance in the first 3 days, and it's how much help did that patient need to complete the task? So if you're talking about eating, the ability to bring food or liquid to the mouth and swallow once the meal has been placed before the resident, we're asking how much of that task did the helper have to provide assistance with? Was it more than half the time? Was it less than half the task? But it's just a different way of asking the question. You cannot take the answers on G and crosswalk that to GG. And you cannot ask the CNA what you would code that person without asking them specifically the intent of the question. So I'm hoping that by now you've got a new method to gather the information from the frontline caregivers in a way that on day 4 in the GG huddle, nursing can bring to the table what they've been able to gather, therapy can come to the table what they believe to be true as far as opportunities and goals and what they're seeing, so we can have a collaborative discussion, and someone needs to take a note, make an entry into the medical record with what the IDT has decided as the usual performance, the goal, and make sure that those are care planned. Oral hygiene is a new area that we just really have not been paying much attention to, I don't think as much as we need to, because it is a driver of your PT and OT reimbursement right now. It will be audited, and we need to make sure that someone is absolutely allowing that patient time to try to do on their own oral hygiene, and then document how much help we had to provide to complete the task. This is definitely, I think, it is falling within the OT realm, to be addressed and to talk to the CNAs and the caregivers about how this person can most independently complete oral hygiene. So that's just an example of something that we really haven't not paid attention to as much as I think we want to. Oral hygiene is very important. There was just an article out last week on the importance to overall health with good oral hygiene. I think CMS is putting their money where their mouth is. They really are putting the money behind what they feel drives good quality outcomes, and which means that they have safer transitions, lower return to acute. So you see the eating, oral hygiene, and toilet hygiene are the self-care GG items. And then the mobility items are what we've been used to seeing, but they're worded a little differently. The tasks are outlined differently, and we have to take the 2 bed mobility items. You code them individually, but behind the scenes, the scoring will be averaging your coding and to get a score. And then the transfers are those 3, sit to stand, chair to bed, and toileting. Those will be averaged, and then your walking will be all averaged, coded, then averaged behind the scenes and scored. And one thing that I ask is, I'm always curious if any of the CNAs and the people that are walking patients on the floor know how far 50 feet is. Do they know how far 150 feet is? Do they know that we need to know, were they able to walk at least 50 feet and make 2 turns? And we need to be accurate in that. So just a reminder to make sure that everyone that's walking with the patient has a way to measure the distance. 50 feet at least, and then 150 feet, just to know kind of how far that is in their corridors. So those are some of my lessons learned on section GG and what I've been hearing as far as some of the struggles that people are facing trying to really accurately capture GG. So Corey, I'm going to turn it over to you to see what you've been finding.
Yeah, so what you're looking at here is, again, numbers pulled from those 21,000 stays across the country in SimpleAnalyzer's data. On the left, you'll see the breakout of the actual PT-OT groups that people have been falling into. And this is kind of what we're going to expect after October 1, which makes sense because the current PPS model is based on therapy already. So a lot of this stuff is being accurately coded already. And on the right, you'll see the breakout based on GG scores. And the sweet spot for the GG scores in PT-OT is that 10 to 23 number. Those are going to be your higher reimbursement levels. So this is kind of exactly what you would expect based on the current PPS model.
Right. I think that we might see some shifts in those GG scores if we truly capture from the minute that person comes into the building through that third, all the way up to that third midnight. I feel like if we really were to capture what was happening at the bedside versus what therapy saw on their 1 or 2 visits in the first 3 days, I think we might see a shift in that. And we really do want to capture that baseline so that we can accurately depict the progress from admission to discharge. So I think that we might see some transition there, and it definitely is based on historical information. And historically, rehab is the one that coded them, so 10 to 23 is what we got. So I think that we might see a transition there. We'll be curious to see what happens into the future. So just the next thing I was going to pull up was just a little reminder again on the cognitive assessment with the BIMS. A lot of frustration on the BIMS. Patients have these memorized. It's not very granular. You can have dementia as a diagnosis and they still don't test out with cognitive impairment. It's just been really frustrating in the field. But one thing I think we might start seeing with people being retrained in the BIMS and ordering the cue cards and getting headsets and making sure that the patients can really clearly hear them and understand them with a new sense of importance, I think that we might see a change in the cognitive patterns just from a new level of education, training, and commitment to making sure that we follow the script and the rules exactly as intended. So again, I think it'll be interesting, and we know we have to redo this with the IPA. It might be a difference. So I think that it's important to document and keep on record all the education and training that has been done, because that might be something that you can defer to if in question why you have a shift in your cognitive pattern scores. So I think that evidence of education and training needs to be maintained on your files, in your HR files. And not to forget, the CMS training videos are outstanding. There's nothing like seeing a demonstration of an interview done right for the cognition and PHQ-9. Swallowing is another area I think that we're going to see some different outcomes, because I don't think that there has been really the effort to make sure we gather this information from every single person on our team who sees the person eat, swallow, and drink. because this is a loss of liquid and fluid from the mouth. There's no diagnosis needed. You know, how many times are we seeing coughing and choking, or holding and pocketing food, or complaining of difficulty with swallow? But I don't think historically knew the importance of how much we needed to document that. We referred to therapy sometimes for those issues, because when someone has coughing or choking, it could be a sign of aspiration, which can lead to pneumonia, which can lead to rehospitalization, which I believe is why CMS has put so much money behind this. The difference between absolutely nothing in the speech category and this one thing alone can be up to $20 a day. And I think it's because they're trying to help us identify critical issues proactively. So it's important that we look at this, we get it right, and if there's a change in the trends in the building, I would again go back to the documentation efforts and make a point that we did do something different to make sure we were accurately capturing this information. It's critical for all the right reasons. Same with mechanically altered diet. I don't think we're missing this as much as the swallowing, just because it's something that requires a lot of attention to make sure we get it in the medical record. There's been a change in the diet. This also is just a check mark in Section K on the mechanically altered diet. There needs to be a reason why we're mechanically altering the food. Just because that's all it requires is a check, there needs to be really good documentation in the medical record as to why that's necessary. And if there's a shift, we better go back to our education and training and why is there a major shift. So Corey, I'm going to look to you again for some data on the swallowing and the speech categories.
Yep, so using that same data set, this is from the perspective of the SLP section of PDPM. On the left, you can see where people are falling into each category. And on the right, this is showing, kind of backing up what Susan was just speaking about, how many people are being coded with swallowing issues. So you'll see there that 75% number. That 75% of these stays had neither in column 2, which means they had no swallowing issues or mechanically altered diet, correct? Captured.
That's right.
Yeah.
That's exactly.
And that number is pretty high. It seems high to me. I suspect a lot of times that information is not making it from the clinical record into the MDS, and that will very negatively affect the SLP rate, your per diem for SLP. So that's something people still need to focus a lot more on improving, I think.
Thank you, Corey. I concur. Okay, so we're going to go real quickly through nursing. There's so much information in nursing now. It's the highest reimbursed category for a good reason. There's a lot of information here because we finally are at a point where we're going to get the reimbursement is going to be based on the clinical needs of the patient and what the nursing staff is having to deliver as far as care for the patient. So there is so much. We just outlined here what the nursing case mix in categories are based on, and the sections on the MDS. Each one is so important, and before we finalize that assessment, we need to make sure, as Corey mentioned a minute ago, the information on the clinical record makes it into the MDS. It's a collaborative game plan here. We have to be communicating and supporting our MDS coordinator and making sure we provide her with all the information that she needs. So Corey, can you speak to nursing and what the findings have been?
Yep, so this first graph is just a breakout of what categories all these patients are falling under in the nursing section of PDPM. And then on the next slide, we're going to show you how many people are being coded with depression. So that's a PHQ-9 score of 10 or greater, correct?
Yes.
Yeah. And so of all of those stays, so that's over 21,000 stays, only 3.13% of them had a PHQ-9 score of 10 or greater. Medical literature would lead you to believe that number should be much higher, probably somewhere between 20 and 30%. We don't know yet, but I know at least I think it's 42% of patients have symptoms of clinical depression. And also looking at the same data set, the people that have a potential for depression, so they're in the special care high, special care low, or clinically complex, it's 52% of this patient population. And then 50% of that patient population is taking antidepressants, according to the MDS. Again, not 100% sure if that is being accurately captured from the clinical record all the time yet, because there hasn't been an incentive to capture it, financially speaking. But I think we will see a lot of changes in this come October 1 in a few days. And I know CMS is going to be watching this one pretty closely because this has a pretty big effect on the nursing per diem rates.
Exactly right. And I think that there is such a big dollar amount here that's put towards depression for another very good reason. If someone is depressed, they're not going to be engaged, they're not going to participate in their therapy as well, they're not going to get out in the community, there's potential risk for isolation. We know there's a lot of negative consequences to overall health if someone is depressed. So I think CMS is pushing us to say, identify depression and address it. So again, retraining on PHQ-9, it's critical to keep documentation of that retraining because you might see changes in trends and you want to be able to back up why. So I think that would be important. Now let's go to the non-therapy ancillary, which is your biggest opportunity to really get paid for what that patient's presenting with, all of these 50 active conditions. Now, half of them have to be identified and diagnosed and put into I-8000 manually, and you have to have crosswalked that on the NTA CMS mapping tool. And if your diagnosis is not showing up in the NTA category that you have, double check, look at what diagnosis would qualify in the condition category that you're finding, and collaborate with your physician to make sure that you capture that. So this is what I think takes a ton of legwork. You're like a private investigator here. It takes everyone's clinical eyes on the patient to identify, hey, I do think they have some of these conditions. Let's make sure that we're capturing this correctly. So, Corey, can you tell us a little bit about what you're finding in this category?
Absolutely. So in this category, this is where we're seeing the most room for improvement right now. We suspect a lot of non-therapy ancillary comorbidities are not being captured in the MDS from the clinical record. If you look at the two colors, the red and the yellow, so it's NE and NF, that's the largest group there. So it's 64% total. And that is a NTA comorbidity score of 0, 1, or 2, which all have a CMI below 1, I believe. So it's reducing the base rate of the NTA base rate. We also calculated the average NTA comorbidity score across this whole patient population is just above 2. And if it was over 3, I think that that's an increase of $20 to $30 per day, correct? Just going to ND, from NE to ND. So that's a huge difference.
Times
so just
3. I mean, that is it's way more,
Exactly. So just capturing one more point for the NTA comorbidity score is a huge difference in the per diem, especially those first 3 days. So we suspect a lot of NTA comorbidities are not being captured. So there's a lot of work to do here.
I totally agree. So let's go to the new HIPS coding, our new language. We're no longer talking about rehab ultra high, very high. We're going to be talking about a new code that tells us a ton of information of what this patient is presenting with. I'm going to skip down to the example. So the first, let's say in the example, the PT and the OT case mix group is TF. You take the second letter in the PT-OT case mix group, and that becomes your first letter of your HIPS code. So TF, the first letter of your HIPS code is an F. Then you go to speech, SD, you take the second letter, and your next letter of your HIPS code is D. For nursing, there's an alphabetical crosswalk that begins with the highest at an extensive ES3 is an A, goes all the way down to the lowest nursing category of PA1, which is a Y. So if the nursing category was special care low, LBC1, you would look over to LBC1 and you would see that it crosswalks to a HIPS character of K. So your next HIPS character would be a K. Your non-therapy ancillary was an NB. Your next category is a B. Your next, letter is a B. And then for your 5-day, you would always put a 1, and for your IPA, you put a 0. So this would be an FDKB1. You know all about that patient and what their conditions are. As long as you dig into T, you know that's a TF, an SD, a K for your nursing, and an NB with, you know how many points you got, and then you got your 5-day. And your default under PDPM is ZZZZZ. And what that is, you take the lowest case mix index of each component. So then we've got CMS is going to be monitoring us in new ways. So this is kind of like the grand finale here, so hang with me. Any significant shift in care between RUG-4 and PDPM could draw significant scrutiny from CMS review entities. That's a quote from CMS. They're going to be measuring our outcomes. They're going to go straight to the outcomes to see what are we telling them in our MDS information that we're submitting. We're going to be looking at their QRPs, the rehospitalizations, and your nursing home compare star ratings. So your QRPs will be based on GG. We're looking at skin integrity, change in mobility, that's the GG, and discharge change and discharge, and mobility and self-care. That's GG's information. That's why I am stressing the importance of the discharge GG. Your QRP claim-based measures that they're going to be watching would be your discharge to the community and potentially preventable 30-day post-discharge readmission measures. And then they're going to be looking at your short-stay 5-star information points of short-stay residents reporting moderate to severe pain and the percent of short-stay residents that had an emergency department visit. Additional PDPM focus audit areas are going to be really honing in on the primary reason for the SNF stay in I-20B. You've got to have the diagnosis to back it up in the medical record, your functional scoring, significant shifts in GG. We've talked exhaustively about that. If you put a new system in place, you're probably going to get new results. You need to document all your training on that. Just like I spoke to that same thing on depression, cognition, swallowing, diet modifications, and comorbidities. Re-education and training could drive different results. And then rehab utilization during the initial Medicare assessment window, that's going to be captured, and Medicare is going to be looking at what we're doing differently. They're going to be looking in Section O at discharge to see how many individual group and concurrent minutes were delivered, and then go straight to our outcomes. And not to forget, follow CMS's Quality Reporting Program training at cms.gov for more updates on what their focus areas are going to be. And then I'm going to wrap it up with, we have a slide on a little bit more about quality rehab management. We're happy to share our tools, answer any questions. We are definitely a comprehensive rehab management organization, helping people who are in-house with their therapy, provide that management support, and provide PDPM training, clinical programming and education, medical review, and recruitment and staffing for our clients. And then I'm going to turn it over to Ken for some simple LTC information.
Okay, thanks, Susan. And just a brief note, so all of the data that Corey covered earlier in the presentation comes from our SimpleAnalyzer product. So it's a very comprehensive analytics program for MDS analysis, but specifically in the PDPM world, you can do things like forecast PDPM revenue. You can look at this very proactive way because the MDS analysis is done pre-transmission, and that allows you to do things like forecast negative trends, overall have a better comprehensive view of your QMs, improve your 5-star, reduce hospitalization, look at frailty indexes, and so forth. So if you'd like more information on either QRM or SimpleAnalyzer, we're going to give you the chance to tell us right now. So I'm just going to launch a quick poll. So if you'd like to learn more about QRM, just click on that, or SimpleLTC's analytics products, or both, or neither. Please let us know. We're going to leave this open just for a minute. And right now, while we've got that running, we can go ahead and start our Q&A portion. Melina has been monitoring the questions as they've come in. I see we've gotten several dozen by now.
Oh, boy.
So we will apologize in advance if we don't get to your question, but we will cover as many of the comprehensive, higher, bigger picture topics as we can before we run out of time today. So Melina, what's our first question?
We recently had a change of ownership and were required to discharge all residents at the date of change and readmitted. Will this have any effect how our IPAs are completed on October 1st?
Oh, dear. Any patient that is currently on Medicare Part A must complete September under RUGs, do not discharge for the IPA transition, but open up a new MDS IPA assessment tool on October 1st and choose an ARD date, any day October 1 through October 7, and your reimbursement for all of your Medicare Part A patients or any managed care patient that's going to follow PDPM rules will be based on that IPA assessment, October 1 through discharge, unless an IPA is completed.
Okay, great. How does bed hold policy work for interrupted stay days?
All I can say is I'm going to default back to the policy, which is if the person leaves your building and they're gone midnight 1, midnight 2, and they come back by midnight 3 before 11:59, then you are able to continue on under the prior PDPM category. If they stay out beyond that third day, then you're going to have to do a new initial Medicare assessment, which would start your your variable per diem all over again. Your bed hold is, I think, taken separately and that's kind of a reimbursement situation for your, a policy for your facility, but I definitely think that we need to make sure we keep the interrupted stay policy and your PDPM reimbursement separate and on its own.
Great, thanks. If an optional IPA is submitted in error and the rate goes down, can the IPA be inactivated?
I am going to definitely refer to the REI manual on that and make sure that you follow very clearly the rules on what you're allowed to do with those assessments. Modifications are allowed. We follow the same rules as we always have for your MDSs.
Regarding Section GG, is it true that the data collection for GG should be completed prior to therapy services beginning for the resident?
No. And that's a great question, and that's probably one of the most biggest questions people have. The language is that the GG coding needs to be the usual performance of that patient prior to the benefit of therapy intervention. So an example would be a patient that is not walking with nursing, they're walking with therapy, but they're only walking with therapy. That is the level of their ability to walk with therapy is not the usual performance. You do not take that into account for usual performance. So I think you need to go back to, what level are they at only because therapy intervened and was taking care of that, addressing that goal. You have to eliminate that from your consideration, but you still score the patient based on the usual performance of that patient in their, from the minute they come to you through that first midnight, second midnight, up to the third midnight, and that's your GG score. Just disregard what therapy has progressed that patient to. I hope that helps.
Are there any items for which the look-back period will change on the transitional IPA versus the RUG-4 assessments?
Your look-back period is the same. Defer to the REI manual if you have any questions, but the look-back windows, I don't believe, have changed.
Okay. Can the transitional IPA and discharge assessments be scheduled on the same day?
Yes. You just can't combine assessments.
Can you clarify if a short stay can be used for those residents admitted September 27th and later who will not have enough days of therapy for a therapy RUG?
I'm going to go back to the prior question just real quick. You have, on the IPA, you have to choose a day when the patient is in the building at midnight. So if they discharge on that day and they're not in the building, you cannot have an IPA with that ARD date. So I just want to make sure I clarified that. Now go back to this question. I'm so sorry.
Can you clarify if a short stay can be used for those residents admitted September 27th and later who will not have enough days of therapy for a therapy RUG?
Only if they meet the requirements of the short stay as outlined in those 8 steps that I gave on that prior slide. So definitely refer to those and make sure you're in compliance with the RUG rules, with the rules under PPS with RUG-based.
Okay. What is the best way to code a discharge goal on Section GG? Is it best to code what we realistically feel like the resident is going to achieve? Is it wrong to have a goal of independent even if they weren't at that level before?
It needs to definitely be realistic because we will be definitely judged on our outcomes based on our progress towards our goals. So I encourage an IDT group discussion on the goals that are set. I oftentimes see 06, 06, 06 all the way down every single item on GG. That is not correct, unless that person truly thinks, we really think we're going to get person independent on all those tasks. If so, great. If not, please don't set yourself up for failure. Be realistic and set goals that you all feel the patient will be able to accomplish by discharge. Take into account prior level of function, all the conditions and comorbidities and issues you're dealing with right now, and make it real, please. Good question. Mm-hmm.
And our last question is, what would be a good drive to ensure that all clinical staff are documenting as much and as accurately as possible?
I do think that the discussions, the collaborative discussions, and the review of all of the items that you're capturing are going to be impactful to make sure that we really do look at what's in the medical record, what's in the MDS before we take that final assessment and make it final. If we do that along the way, if we can have a meeting where we're pulling up our software, where we're looking electronically at our documentation at the same time we're having collaborative discussions on what category we're going to capture in the MDS, I think it's a good step along the way to make sure that we're complete and supporting our MDSs. It's a good question, and it's a great effort. I appreciate that. It's fantastic. Okay?
Okay, great. And Susan, I think you had a couple of references you wanted to cover.
Oh, sure. I just think that it's important that everybody has handy the REI manual, as I've alluded to many times, and the CMS PDPM update, and that you feel really good about, having the October 2019 MDS, the comprehensive assessment, and the IPA assessment tool at your fingertips, so that you can refer to it often. The answers often are in the MDS actually themselves. If not, in the REI manual is where you got to go. That's the first stop for questions. Thanks.
Okay, great. Well, thanks so much, Susan. I want to thank Susan Kroll, Chief Strategy Officer with QRM, for joining us today and putting together this information in advance of October 1st, which is coming very quickly. So thanks so much, Susan, for being with us today, and also Corey Pauley, Director of Engineering with SimpleLTC, who has spent some time highlighting some specific information and data out of SimpleAnalyzer. And then also thanks again to Texas Medicaid Coalition, or TMC, which is our sponsor and presenter of the webinar today. So if you are looking for a recording of today's webinar, we will have that available later this afternoon, as well as the slides if you missed those earlier. So there's the URL on your screen, simpleLTC.com/PDPM-IPA. So give us an hour or two and we'll have all of that information up as well on the website. So thanks so much to our speakers today and for everyone for attending. Have a great day.